Hi, ma'am. Good evening. Ma'am, your mic is mute.
Hi Juan.
Hi, Aditi. How are you?
I'm good. How are you doing?
Good. Good to see you.
Yeah, good to see you.
Yeah.
How's
This
work?
is
Quite
Jenny.
busy?
It's good. It's good. I want to introduce you Jenny Villamizar, who is one of our transplant intensivists here in Miami.
Oh, great, great. Nice to
Hey,
meet you. Thank you so
nice
much.
meeting you too.
Thank you so much for speaking at our webinar this evening or this
Of
morning.
course, thank you for having me.
Absolutely. So we're very excited for this. So Society for Heart Failure and Transplant is one of the eminent heart transplant professional societies in India with heart, lung physicians and surgeons. And we started doing webinars this year. So we're hoping to have more involvement, engagement from international faculty as well. So we're really excited to have you and learn from you. And, our experience here is still evolving. Um, a lot of complications and issues that we see here, I didn't like really experience in the US. So it's been a great journey.
Well, that's exciting.
Yeah. And your
How long
number
you been? How long you been back?
3 years, almost 4 year, four now.
Almost 2 years.
Yeah.
Awesome. That's very good.
Yeah. So Miami's busy.
Miami's busy. We did 85 transplants last year.
Oh, wow.
So we quickly became the largest center in Florida, and we're top 10 in the country now.
That's
So
amazing.
super exciting.
Great, great.
Training people, recruiting people,
Yeah, yeah.
expanding. So very exciting things happening.
That's great. Yeah, I keep speaking to Shweta also. So you see all kinds of infections over there, which you probably wouldn't in like the rest of America.
That's right. A lot of mycobacteria, more aspergillus.
Yes, yes.
We even had a mucor outbreak in our unit, which was
Outbreak. Yeah,
fun,
that's probably air filters, vents.
terrible.
Yeah, yeah.
But yeah, good times. Are you coming to SHLT?
No, not this year.
Nice year. Okay.
Yeah, yeah. Toronto's where you trained, so I'm sure you're going.
Yeah, we're super excited. We're going back to meet a bunch of people, and I try to go
Exciting.
every year.
Yeah, yeah.
Um, so far I've been lucky that I haven't missed any, I
Yeah.
think, in 10
Yeah,
years.
I would. It's just too far.
Well, I missed the one in Australia, the one that they
Yes.
canceled for
Yes,
COVID.
yes. I want to go to the one in Australia. We're
I guess we
hoping.
all missed that one.
Yes, yes. Hoping to
Yeah.
have a presentation for
I
that
don't
one.
know. Yeah, I don't know if you remember that year we did we did we did an online ISHLT.
Yes, COVID.
It was terrible. It was
Yeah.
awful. People at home just listening lectures for like 3 days.
Yeah, yeah. It's hard to do that. You can't sit in
Yeah,
front
yeah.
of the screen for 3 days.
I know. No one hitting the bar after a whole day of.
I know that's the most fun part, right?
That's right.
Networking, meeting friends.
I know. It's good to reconnect with people.
Yeah. So I'll introduce you to Dr. Talha. He is the academic co-chair of Society for Heart Failure and Transplant. He's a transplant cardiologist trained at Allegheny.
Fantastic.
Talha,
Thank you.
you here? Maybe he's logged in, but yeah.
MC is working on it.
Hmm.
I'm just gonna lock my office. I'll be right back.
Okay.
Hi, Aditi.
Hi.
Hi,
So
Dr. Khan. Hi.
Hello.
Hi. So nice to see you in person. I look forward to your talk. Even though
Good to
I'm
meet you.
a
Thank you.
cardiologist, I want to learn more. We just keep hearing these terms.
Very, very different. It's very different.
Yes.
Right.
Yeah.
So, one of our moderators, Dr. Apar, unfortunately can't join in. But we have Dr. Dr. Unmil Shah. He will be joining us soon. He's a transplant pulmonologist.
Fantastic. I think he just joined, Dr. Shah.
Hi, good evening, everyone.
Hi, Unmil.
Hello.
Hi.
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 Also want to introduce Dr. Villamisar, Jenny, who is one of our transplant pulmonologists here too in Miami.
Hi.
Hi,
Nice.
everyone.
Hello, hi. Dr. Unmil, Dr. Apar has a family emergency, so he won't be able to join. He just told us about half an hour back. So
Okay.
if you can carry the mantle and do the moderation
Yes.
after the talk, yeah.
No problem. No problem. Yeah.
So Dr. Unmil is part of a busy lung transplant program with KIMS and also at our hospital. He frequents all the ISHLT meetings and moderates and chairs all the sessions. Not sure if you know him from the ISHLT meetings, but here he is.
I don't think we have met.
No. And right now I'm in the midst of a lung transplant in the hospital. So already one lung transplant going on. Yeah.
Fantastic. What hospital are you at?
So this is HN Reliance Hospital, Sir HN Reliance Hospital at Mumbai, India.
Fantastic.
Yeah.
Fantastic. You've been doing lung transplants for a while, or?
Yeah. So my team has now done more than 400 lung transplants.
It's amazing.
I mean, since 2017.
That's fantastic. Congratulations.
Thank you.
Unmil, I'm just curious, where's the donor from? Is this the Jupiter donor?
Yes, Jupiter. Yeah.
Okay. We turned down the heart, yeah.
Yeah, I think it's 90% LAD or something, right?
Yes, yeah. So we're about 2 minutes away.
Dr. Shah, are you coming to ISHLT this year?
Yes, I will be coming to ISHLT. I'm a coach.
Fantastic.
Yeah.
तो अभी ऐसा करो
I'm
अभी आए पीछे वाले आए नहीं आए थे
putting my cell phone in the chat in case you want to connect in ISHLT. It'll be good to chat.
We'll just wait for a couple of minutes if that's okay. So give some more time for people to join.
चालू है ना ऑडियो और ये सब? ओके, थैंक यू.
अभी हुआ नहीं.
Dr. Aditi, should we start? You're on mute.
Yeah, I think in the interest of time, I'm sure Dr. Juan and Dr. Villamizar have to get their day started. It's morning over there.
Right.
So maybe we can start. We have a few people, and I guess people will continue to join
Right.
over the next few minutes.
Right. I see Dr. Jabir is also logged in.
Yes. Hi, Aditi. How are you?
So good, sir. Thank you for joining.
All right. So this is part of our webinar series from Society for Heart Failure and Transplant India. We have two very special guests who will be speaking to us on chronic lung allograft dysfunction. My co-host, Dr. Aditi, will be introducing them soon. We also have a special guest moderating who will be moderating the session after the talks. He's Dr. Unmil Shah. He's a transplant pulmonologist based in Mumbai and also works with his team at Kim's Hospital. He's a pulmonologist with background with a large experience of lung transplants, and his team has done over 400 lung transplants in India over the last 9 to 10 years. So the listeners, I'm sure, are looking forward to hearing this talk. So Dr. Aditi, please take it away, and we are eager to listen to Dr. Juan and Dr. Jeannie.
So we're very excited to have with us two physicians from University of Miami, which is one of the largest lung transplant centers in North America. They've just done 85 lung transplants in the last year. So Dr. Juan Fernandez Castillo has done his lung transplant fellowship from University of Toronto and a master teaching program as well from Toronto and Masters of Public Health from University of Miami that he's currently doing. He's a transplant pulmonologist and intensivist at Miami Transplant Institute, Jackson Memorial Hospital, and he's involved in multiple multi-center research trials aimed to improve outcomes in lung transplant and has several publications in peer-reviewed journals. And we also have with us Dr. Jeannie Villamizar Rivero. She's a transplant pulmonologist and critical care intensivist, also at Jackson Memorial Hospital, University of Miami. She's done her fellowship from University of Miami, and before that it was in Venezuela. She was also a research fellow at University of Miami. She's had extensive experience in research as well, working on projects with regards to pulmonary hypertension and lung transplant, and has also given oral presentations in multiple international conferences. So we are very excited to have you and learn from you, and with that we'll get started.
Awesome. Thank you so much for the introduction. And thank you everyone for attending. We have no disclosures, and this is going to be our agenda. We'll start with some case presentations. We'll go over CLAD overview. We'll talk about epidemiology and outcomes. We'll talk about treatment and management, and we'll close with future directions and closing remarks. This is my part one, and this is a case of a 59-year-old woman with interstitial lung disease. She underwent bilateral lung transplant back in September of 2023. Serologies were CMV, donor positive, recipient positive, EBV donor positive, recipient positive. Her virtual cross-match was positive before transplant, so she underwent desensitization protocol, which for us is the plasmapheresis followed by IVIG followed by thymo. Her actual cross-match was negative. In summary, her postoperative course was characterized by primary graft dysfunction grade 3. In October 2023, she was discharged home from the hospital to the acute inpatient rehab facility. And this is her imaging. This is right prior to discharge. And just as a FYI, we do our standard immunosuppression. We use induction with basilizumab, and for standardized immunosuppression, steroids, arsenized tacrolimus, and mycophenolate. This is a brief overview of her post-transplant course and her surveillance biopsies. So as you can see here, she had LDLT was performed on ECMO. She had bilateral lung volume reductions. Her first transbronchial biopsy was done in November 2023, which reported a A1B1R rejection. For this, we treated her, and this was her first episode of rejection. Following month, she had an infection with Pseudomonas, and after that, repeated biopsy in January, she continued to have an A1BR, which she treated for rejection. There was a following biopsy, which was read as A0B0, perhaps not enough samples. We did have to treat her again in July 2024 for rejection. We were not able to perform transbronchial biopsies due to her tenuous respiratory status. And in August, her FEV1 dropped to 0.81 liters, which is less than 61% from her peak. And in October, our plan was to initiate ECP. And in July 2025, we had to free transplant her. Again, this is just a brief summary. And this is a comparison of her images from December towards September. And her phenotype is BOS, therefore there's no changes in imaging. And this is a graph, which is depicting the trend and the changes on her FEV1. As you can see, her peak was 2.07 liters with an added of 0.81, and her decline was less than 61% from her peak. So to summarize the workup, or the main important things for this patient, is that she had some abnormal GI testing. She had an esophageal manometry done that reported a hiatal hernia of 2.6 centimeters. She had 80% of ineffective esophageal contractions. She also had incomplete bolus clearance. And in her impedance testing, it was completely abnormal with a D-Mister score of 20.7, with 70 total reflux episodes and 10 proximal reflux episodes. Therefore, some very significant pathological curve. And in the bottom of my slide is just a summary of the pulse steroids, the extra thymo that she received, and the intention to initiate ECP on her. And with this, I'm going to move forward for our next speaker, Dr. Fernandez, and I'll come back to talk to you at the end for closing remarks. Take it away, Dr. Fernandez.
Thank you, Jenny. That's a great case that we had recently, and thank you for the organization for the invitation. We're super excited to be here, and I'm going to jump into CLAD. So we know transplant activity has increased significantly over the past few decades, exploding, especially in North America, where we both practice, me and Dr. Villamizar. With really improving outcomes, slowly getting our first year survival, our medium survival of 5 years much better. But of course, we still have some limitations. Next slide, please, Jenny. We know that our long-term survival is not even comparable with the other organs. For a fact, for the audience here, the heart transplant patients tend to have a much better long-term survival, and we're kind of stuck still into the 5 to 6 year medium survival. Next. And we think this is related to the development of chronic rejection. And we know for a fact that chronic rejection is not also very prevalent and is very common, but at the same time is probably the first cause of death after the first year post-transplant. If you see here in this algorithm, you'll see the most patients will have some degree of chronic rejection after 5 years of their transplant. Next, Jenny. This will be 50% at 5 years. Next, come back. Come back one. And almost 70% of these patients will have some degree of chronic rejection at 10 years. And we know for a fact that this is the first cause of death after the first year post-transplant. We will continue to the next slide. So you see that if you go through the causes of death in the natural history of lung transplantation, we know that initially graft dysfunction is an issue. We know that PGD is a major cause of death within the first 3 months or 90 days post-transplant. We know for a fact that infections play a big role. But really after the first year, we start encountering problems like malignancy and being the first cause of death, chronic rejection. In this case, manifested as a BOS. And we're going to talk about the different flavors of chronic rejection later on. Next, please, Jenny. All right, so let's jump into CLAD definition. This is the most recent consensus for the International Society for Heart Lung Transplantation, where they went through the exercise of not only describing CLAD, but also having a clear definition of CLAD, and also the implications in the severity and the phenotype of CLAD. So if you want to go into the strict definition for CLAD, based on this SfHFT consensus, you will say there is a diagnosis of exclusion. And it's a diagnosis of exclusion because part of the diagnosis and follow-up for someone that is developing CLAD after an initial insult or acute injury involve the active investigation of things that can be reversible. Because we know that CLAD is persistent and irreversible damage to the lung as manifested as chronic rejection. So if we define it will be a substantial decline, which is 20% more than the baseline FEV1 post-transplant, followed by a persistent decline, defined as definitive CLAD if it's persistent for 3 months. And of course, we have the phenotypes we're going to describe later on. We have the BOS, RAS phenotype, mixed pictures, and classified. If you look into the CLAD staging, you're basically talking about severity. Very common is the things that we describe with COPD. When you look at the FEV1 and based on the percentage, we'll decide how severe this disease it is. So of course, you have CLAD 4 when the patients have very, very decreased FEV1, which is less than 35% of their baseline. Next slide, please. And this is just an exercise to see how do we make the diagnosis of CLAD. And Jenny, just a heads up, I'm gonna go next and just gonna do one click, okay? So this is a 38-year-old female that we transplanted back in Toronto when I was still there. And I saw in clinic with established CLAD. If you see here, you see like natural history of the FEV1 picture going after transplant to a max level of 2.2. Click, Jenny. And you can see right there that the peak FEV1 is about 2.2 liters. And then the way that we establish what the best FEV1 will be in this scenario will be to capture the best 2 FEV1 that might be separated by at least 3 weeks, just to make sure there's a good solid trend of PFTs, and then we do the mean of those 2 values. You have an FEV1 of 2.2 and one of 2.1. So what do we determine this being the baseline? At 2.115. So like any other transplant patient, they develop complications. Click. Any? They had a drop in lung function. In this case, it has Pseudomonas pneumonia. We bronch her. We did antibiotics, and then unfortunately she continues to progress to the point that she dropped again her FEV1. At that point, we did another biopsy, and then we found she had A2 rejection. She was pulsed with steroids, and her lung function recovered. But it recovered not completely to her baseline. So you have some degree of graft dysfunction, but technically still not fulfilling CLAD criteria, because if you do the calculation of that FEV1 based on the best FEV1, it's still not below 20%. So it's developing CLAD. But the important feature is like over the past few weeks or months, you've been working this patient up, you're trying to rule out things that can be reversible. So actively investigations as your patient is developing CLAD is the key in order to modify those risk factors and try to preserve or recover that lung function before it becomes definitive CLAD. And if you see, click again, Jenny, the patient got another drop of PFTs after that. In that case, she developed AMR. And you can see that being a significant drop due to this severe antibody-mediated rejection. And despite treatment, she recovered, but never went back to the initial baseline. And at that point, after having a persistent decline of FEV1, persistent for 3 months, after multiple investigations and treating reversible causes, then we establish a new baseline. So at that point, this patient has established CLAD. Click, because we know is substantial, more than 20%. Click, we know is persistent, more than 3 months. click, and because we know we exclude any other potential reversible factors that might help us preserve this lung function. Let's go to the next slide. All right, so CLAD phenotypes. CLAD have multiple flavors, right? We have our obstructive patterns, BOS, which is the most common one, and you have RAS, which is your restrictive allograft syndrome, which is the most scary one because there's a lot of fibrosis, there's a diffuse fibrotic changes, and their survival is much lower. I'm going to show this in a graph later. But it also gets a little bit complicated when you have all these mixed and defined phenotypes that don't fulfill the strict criteria for BOS or RAS. So BOS, to call BOS, you have, of course, a 20% decline, persistent FEV1, diagnosis of exclusion, but you have an obstructive pattern based on PFTs, no restriction, and no CAT scan findings suggesting fibrosis. So that's your clear, pure BOS. You have a RAS patient, who will be someone that has no obstruction, restrictive physiology, and CT scan that is consistent with fibrosis. Next slide. Now, if we talk about the specific of each one, you can see here very clearly that on imaging and on the pathology, you'll see all these accumulation of fibrin and fibrotic changes are located in the terminal bronchial, in the respiratory bronchioles. So this is an airways disease. The reason why it produces an obstructive pattern in PFTs with the absence of restrictions. Luckily, this is about 25 to 70% of patients diagnosed with CLAD, which it carries a better prognosis than the other flavors of CLAD. Let's move on into RAS. You can see here very clearly, that when you have a more homogeneous, more spread out fibrosis markers, either on pathology or even in imaging, you're dealing with more like a restrictive pattern. So we call it RAS when we have a persistent decline in FEV1, a CLAD diagnosis standard, but at this point you use the TLC. Now, the guidelines suggest using TLC as the absolute way to diagnose restriction post-transplant, but we also recognize, or the society recognizes, that not everyone has access to TLC. So if you want to use a surrogate of restriction in the absence of total lung capacity or total lung volumes, you can use the FVC and a switch of 20% to call that restriction. So it's not the standard definition based on TLC, but you can use the FVC as a surrogate to call someone restrictive or RAS, in particular when they have these classic RAS-like opacities. We see basically CAT scan findings that are persistent that might suggest that are the cause for the restriction, right? So it's important to establish that RAS-like opacities are very clearly fibrotic changes with pleural thickening, very similar to fibropulmonary elastosis, in addition to thickening of the parenchyma and classic restriction, or suggesting a restriction in PFTs. Next. So I really like this graph from 2011. I think it was published by one of the fellows in Toronto when they look into images, pathology, and immunofluorescence. And it's very interesting to see how the fibrosis that look completely spread on X-rays and CT scans is very, very similar as you see in the pathology and immunofluorescence. You can see here fibroblasts invading the entire tissue, alveoli sacculars, basically a widespread fibrosis, whether when you look into the BOS perspective, you'll see that the fibrosis is mainly localized at the airway level. And this bringing the hypothesis that perhaps BOS and RAS is the same spectrum of disease, just in a more severe forms. But there's been also some links in the pathophysiology suggesting that there are a difference in what the autoimmune trigger will be. I'm going to talk about that a little bit later. Next slide, please, Jenny. All right. And why do we care? Well, we care because it's the first cause of death after the first year, right? We're shooting to improve survival for patients post-lung transplant. And we care because if you develop BOS, your survival is lower. And it's more important to establish what phenotype you're actually dealing with for multiple reasons. One, because if you have a RAS, you can have that honest conversation with your patient that RAS CLAD is very likely to progress and your survival is much lower than if you develop BOS. And more importantly, help us trying to stratify patients for research and to follow up in clinical trials to kind of establish what will be the mechanisms in research or bench science, in addition to categorizing what patients will be more responsive to therapy, or if we have different therapeutics for different phenotypes of CLAD. Next, Jen. So when you look into the CLAD, one more click, you see how confusing this gets. You have a BOS and you have RAS-like, and you have all these mixed undefined pictures. We don't really know what that means. But I always like to mention this paper published by Teresa Martineau in Toronto. That was just a couple of years ago. If you go next, Jenny, please. You can see how widely and confusing this can get, with like multiple ways to put a patient as a label as undefined and classified based on obstruction patterns, restrictive patterns, having both, having opacities, maybe they're no opacities, maybe they're RAS-like opacities, maybe they're opacities that they don't look like RAS, they're more like inflammatory. So the things became very confusing. But what we do know is that fibrosis is bad. And I always like to mention this paper next, Jenny, because it helps us understand that fibrosis is bad. We have patients with IPF, ILD. Once they develop honeycombing, they're likely to have worse outcomes because they are progression in their disease. Here is a nice way, and they're looking into how the different types, the RAS ones, which we knew about, and the mixed pictures were the patients that did worse, comparing the other unclassified, undefined, and BOS picture. And this is because we're suspecting this patient has more severe disease. And when you analyze this based on their fibrotic changes, next, Jenny, when we look into all this, one more, when we look into all these different phenotypes and classify them based on the RAS-like opacities and evidence of fibrosis on CT scan, it is obvious that the patient has more fibrosis is going to do worse. So it helps us not only understand what the prognosis will be of our patient, but also help us understand potential therapeutics and looking into the future, how we're going to address this, how we're going to define these patients, and how we're going to intervene. Next slide. Let's talk about CLAD mechanism. We're not going to get too technical, but the bottom line that we need to really understand is triggers are important, and different triggers trigger inflammation that leads into acute inflammation, that leads into recurrent inflammation, that looks into chronic inflammation, and then into fibrosis. Because in simple terms, we have an injury, and if that injury is constant or this injury is recurrent, you're more likely to develop chronic inflammation and from them fibrosis. That's kind of a classic concept for most diseases that we see and most pathophysiology. And you have here, this is very important to look into our airway epithelial cells. So either there is an injury that is exogenous, let's say pneumonia, pseudomonas, CMV, all type of infections, or chronic aspiration, silent aspiration, or if it's endogenous, just based on rejection and leading into perpetuating inflammation. This pathway, what is going to lead is into a discontrolled dysregulation in between the innate response and the adaptive response. When you see initial innate response leading into T cell activation, APC presentation, perpetuating inflammation and antibody production, and the most important aspect of CLAD is the disbalance between T helpers and T regulatory cells. And we'll see this balance of growing inflammation leading into increasing dysregulation of healing, and at the same time, the positive of fibrosis, fibrogen, and myofibroblasts. That can be either at the airway level in the case of BOS or diffusely in the case of RAS. Next, Jenny, please. Right. So I like to always to link these exogenous and endogenous triggers to what the risk factors are. And it's very nice because we have established that all these triggers are risk factors. If you have an idea, like you have inflammation that is severe, can lead into CLAD. So the first example will be PGD. Next slide, please, Jenny. We know that PGD is the first cause of death within the first 90 days post-transplant. We know that very severe forms of PGD are very difficult to treat, and they have implications not only in the short term, but also long term. If you have someone with PGD1 at 72 hours versus someone that has PGD3 at 72 hours, you know that the patient with PGD3 is more likely to die during that hospital stay, comparing someone that has no PGD or more benign forms of PGD. But it is very interesting is that even this very early injury has been linked with outcomes later on. You can see this nice paper. This is almost a hallmark paper that we all used when we talk about PGD risk long and short term. You'll see that not only PGD is linked with chronic rejection, like many days after the initial insult, but it's also linked with the severity. The more severe forms of PGD have higher rates of CLAD, suggesting that that initial insult has some implications into the ongoing dysregulation in chronic rejection. Very big risk factor. Next slide, please, Jenny. So same with recurrent inflammation. When we have persistent ACR, recurrent ACR, or more severe forms of ACR, you're more likely to develop CLAD because you have ongoing inflammation. And this is something that we see anecdotally in patients that perhaps are not taking their medications or having some adherence issues. They're having these recurrent A2s. Eventually, they'll lead into CLAD. And we do the same not only for severity of the injury, A2, A3, A4, but also the patients that recur, having A1 recurrent, A2 recurrent in different biopsies. Those patients are more likely to develop CLAD. Again, recurrent inflammation leading to chronic inflammation. Next slide, please, Jenny. It's also important to recognize that there's like a humoral component in the pathophysiology of CLAD. And this humoral component has been described not only at the clinical aspects by looking into what these DSAs do with the allograft overall and the risk for DSAs and the risk for CLAD, which is clearly documented in this paper by Dr. Tikkanen, Jussi, when he was still a fellow in Toronto. So what he did is he looked into all these antibodies and was a strong link between DSAs and CLAD, but more importantly, the class 2 DQs. That's why we're very concerned about those DQs, and we're very, very proactive about treating them, even though our evidence of treating asymptomatic DSAs is not very strong. We still believe that if someone has ongoing DSAs at a higher risk, and we see that not only with lung function, we see it with DQs and cell-free DNA elevation, transferred cell-free DNA and persistent DQs. We've seen that and recently published, and we're very concerned about these patients. So once your patient develops DSAs, the stratification of the immunological risk is completely different, and the idea will be to try to manage the immune suppression a little bit higher. Next slide, please, Jim. Let's talk about other triggers. We talk about the exogenous triggers, Pseudomonas, infections. So we also know that it's been described anecdotally that when we have someone that is newly colonized with Pseudomonas, someone that didn't have Pseudomonas pre-transplant, and now they have 2 isolation of Pseudomonas, impossible to eradicate, those patients tend to develop CLAD, higher rates of CLAD. And this is why another strategy for most programs is to be extremely aggressive, in particular with Pseudomonas eradication. We have different protocols where you do at least 14 days of therapy and start inhale antibiotics, which is recommended anecdotally for patients that already have a structural lung disease, patients with CF or bronchiectasis. So we're very liberal and very aggressive at using both IV antibiotics, longer durations of therapy, in addition to inhale antibiotics with someone that is getting isolated Pseudomonas for the first time. Because if we know that becomes a chronic colonization, it's being linked with worse outcomes, including that. And the same with Aspergillus. Next slide, please, Jimmy. All right, this is one of our favorite topics and one of our favorite topics here in Miami, because we do a lot of GI testing, a lot of interventions. So one slide, one click, Jenny, another click. So we know that patients with advanced lung disease are at a high risk for reflux. There's a lot of reflux. And what we know is it's also very silent. You try to stratify who has reflux based on symptoms, and then you compare that to actual testing, impedance testing, pH manometry, whatever you want to do or you have available to you. It's like flipping a coin. Patient can have horrible pathological reflux and having no symptoms, and the other way around. And this is important. Why? Because reflux is very prevalent in patients with lung disease. Next, Jenny. And it's also known to get worse after your transplant. This is a nice paper. It's an old paper now, but they look into testing in the same population, the same cohort. Pre-transplant reflux testing, post-transplant reflux testing. Every single one, if not most of them, got a worsening reflux documented by acid contact time before and post-surgery. So reflux is very prevalent. A lot of patients with lung disease have them, and then you know it's going to get worse post-transplant. And this is why it's relevant. Next slide, please, Jimmy. We know that reflux documented, specifically in this paper by the Duke group, looking into distal and proximal reflux episodes. You know, the patients that have more pathological reflux develop a lower peak and first-year FEV1. So it seems like they have a trend to have a lower lung function in the setting of having pathological reflux. Next slide, please, Jenny. And this is not just documented based on PFTs, but documented based on biomarkers of aspiration. This is a paper also published through the Duke group. Actually, no, this is from Toronto, where they look into bile acid into bronchoalveolar lavage. And this was in higher levels of bile acid as a surrogate of aspiration in bronchoalveolar lavage post-transplant was clearly linked not only to worsening rates of CLAD, in this case BOS, because this was before the RAS definition. But these patients tend to develop early CLAD. So they even develop early BOS within the first year post-transplant, which is very concerning. And this is perhaps something what happened to our patient. They developed very early CLAD within the first 2 weeks because she had pathological reflux that weren't able to jump into fix because she had other issues or readmissions to the hospital. Next slide, please, Jenny. Now, it's nice to correlate PFTs, FEV1 with actual objective data of reflux. It's nice that you correlate these bile acids into perhaps more chronic rejection, but it's also interesting to look. And this paper was published by Kevin San, one of our med students in Toronto with Dr. Martin. So he looked into bile acid, but correlated bile acid, in this case TCA, but correlated not only with the objective GERD study, in this case was impedance testing, in addition to inflammatory markers. And it was very clear that if you have reflux, you have higher levels of TCA in the bronchoalveolar lavage. And if you have reflux, you also have higher levels of inflammation that have been already linked to CLAD and graft dysfunction or ALAD in general, which is very interesting, putting all together the physiology, the inflammation, the CLAD onset, and the markers of aspiration, which have no doubts in my mind that there's a clear link with reflux and chronic rejection in general. Next, please, Jenny. So let's talk about CLAD prevention. So one of the few things that we've learned through the year based on a few really landmark studies, and this is probably one of the strongest studies that look into the use of azithromycin to prevent CLAD. We all have different thresholds to start azithromycin. There's different practices of whether start azithromycin at the time of CLAD onset or started early on upfront to prevent CLAD to begin with. So this is one of the studies that I like the most, and looking into several patients and the early initiation of azithromycin at the time of transplant. These patients actually ended up getting IV azithromycin just a few days post-transplant. They continue a regimen of 3 times a week. So we looked at the onset of BOS in patients receiving azithromycin was much lower. So you see that response in FEV1, and I think it's very, very accepted now in the transplant culture that we should be doing azithromycin either for prevention or once we have established BOS. One, because we've seen it working in several studies into preservation of FEV1, but we also seen a dramatic decline in neutrophilia in patients that had predominant neutrophilia on BL. So there is a role, an anti-inflammatory role, looking into CRP levels in addition to BL neutrophilia that might tell you not only that this might be what we need to do, but in addition, it gives you an idea of who is more likely to respond to azithromycin. Because when you look back in these studies looking into neutrophilia and azithromycin, it seems to be the patients that have neutrophilia predominance in the BL, the ones that have a better result with azithromycin. So we do that routinely, cell counts routinely in all our surveillance bronchoscopies. And if our patient is not in azithromycin and they have neutrophilia, this is the patient that we, unless have any major contraindications, we would go ahead and start azithromycin without hesitance. Next slide, please, Jenny. Right. The other interventions for prevention, if you have someone that is developing CLAD or someone that is at risk for CLAD, then and they have reflux, so the idea will be try to fix this reflux. And there's been multiple studies, mainly anecdotal, retrospective, not really good controls, but we've seen in multiple cohorts, especially Dr. Harwin from Duke, look at this multiple ways. And this is one of the landmark studies where he presented fundoapplication as a way to reverse that lung function. And you can see how after fundoapplication, the patients that had documented GERD, their lung function actually was superior or not very similar to the ones that never had a GERD to begin with, which is a very strong signal that perhaps this is the way to go. And there was a recent paper published also by Kevin San not too long ago, where we look not only the FEV1, but we look into the TCA levels on bronchoalveolar lavage, and we also look into inflammatory markers pre and post fundoapplication. And FEV1 got better in those patients that we were able to wrap and fix, and the TCA went down significantly, the bile acid on those patients, and in addition, the inflammatory markers in the BL also decreased significantly. So there must be a link, we just don't know which patients we need to intervene right away. I think there's a lot of room for more research into that scenario. Next slide, please, Jenny. Now, we know that if you have pathological reflux and then you have signs of aspiration and your CLAD is getting worse, then perhaps it's not too difficult to make the decision that reflux needs to be fixed. But we're always concerned about when to do the reflux surgery. And there's been multiple cohorts showing that typically the early intervention is the best. We have this paper published by Duke when they said that the patients that had the reflux surgery within 6 months of transplant, with a normal testing, of course, they did much better. And the late fix of this reflux was not the best approach. UCLA recreates something very similar with a 90 days of intervention where the patients did much better when they reflux the surgery. They fixed the reflux within 90 days of the transplant. Our program emphasizes to try to fix it within 6 months if you have pathological reflux and you have concerns about the safety of the graft. Next slide, please, Jenny. And the other thing that we all discuss is it safe? Can I safely do a fundoplication on a patient post-transplant? One click, Jenny. One more click. And one more. Thank you. So what we see here is that comparing hundreds of patients that went through fundoplication as our control group with all the transplants that went through fundoplication. This is a study was published over a decade ago, but I think it's very important because you look into the inpatient mortality for someone that you're doing a reflux surgery versus someone else, it was pretty much the same. And then you look into the pulmonary complications, there was also no difference. So which is interesting that you have a highly selected patient, you otherwise think they can go through the operation because they still have a good pulmonary reserve. There's really no reason not to do it if you think this is affecting the graft. And the same idea will be that, of course, these patients stay a little bit longer in the hospital. And these patients, of course, cost more money because, they have immunosuppression and they were longer in the hospital. But it seems that the safety was not an issue based on this large retrospective study. Next slide, please, Jenny. So let's talk about ECP. And ECP is one of the few interventions that, in my opinion, apart from trying to stabilize someone, treating the reflux or doing azithromycin, has showed some light at the end of the tunnel in terms of treatment for chronic rejection. We know the pathophysiology is really poorly documented and really unclear and unknown, but the idea will be to make those regulatory T cells to work a little bit better, decrease the cytokine storm that is happening from CLAD or from acute rejection, and modifying the APC so there's no more allograft recognition. Next step, Jenny. And there's really not a lot of strong data, but I think the most experience we get from ECP is from Europe. And I think Alberto Benasso did a pretty good job here at describing almost like 20 years worth of data, like probably more like 40 years worth of data from transplants from the late 90s all the way to the late teens. The largest experience in seeing patients receiving ECP. Now, the caveat of this paper, and it's extremely important, there was no control. All they did is they look at hundreds of patients, about 600 patients, they receive ECP at some point after their transplant. And they look at the trends, and there was a good proportion of responders, which responders means they either stabilized the lung function or they got better, a very small proportion. And the non-responders, which is the ones that have a continuous decline of FEV1 despite the start on ECP. And they use that cutoff at 10%. And I think this paper is important not because it gives you the answer that ECP is the way to go to treat CLAD, but it tells you that certain nuances about CLAD that tells you what patients are more likely to respond. And when they look at the patients with BOS, we're more likely to have better outcomes. And the patients that started early treatment of ECP, now waiting until they're CLAD 4, they tend to have a better survival as well. And the most important thing, I think, is that it was perfectly safe. So apart from having the issues of having to need a catheter and going to the sessions, twice a week and whatever protocol you follow, eventually once a month, it seems to be safe with not a lot of major side effects. So something on the works to consider as another tool to treat or prevent CLAD. Next slide, Kenny. Now, we got very excited about this recent paper also published by Alberto, where they look into ECP as prevention, not treatment of CLAD. And they look into a very, very unique cohort of patients recently. And this is very common for Vienna, having a lot of COPD patients. So 62 COPD patients post-lung transplant. And they compare standard immunosuppression versus standard immunosuppression and the initiation of ECP as early as 2 days post-transplant. And they use a composite, outcomes, but bottom line, it was interesting to see that not only the CLAD rates were better in patients receiving ECP, but they saw less high-grade ACR within the first 24 months. And that's extremely valuable because we have always those patients that were struggling with recurrent rejection early on post-transplant. Third pulse of steroid, fourth pulse of steroid the first year, and no matter what you do in the immunosuppression, you switch to belatacept, you add an mTOR. We've seen these patients once in a while that you just cannot control the rejection. And I think it's good to have an idea that we can potentially use ECP not only to prevent CLAD and treat CLAD, but also to control acute forms of allograft dysfunction with this very, very early paper recently published. So this is creating a lot of appetite to use more ECP with whatever level of evidence we have so far. Next slide, please, Jenny. So what about retransplant? And this is one of the things that want to discuss. Next slide. So retransplantation is doable. We've done 2 retransplants since we started our group in 2022. And of course, it only works if your patient is highly selected. And by highly selected, I mean someone, and we're going to talk to some features that are increasing your chances for better outcomes in retransplantation. Retransplantation represents about 4 or 5% of all the transplants done. It's usually reserved for patients that are otherwise young and healthy that develop chronic rejection, but not a lot of complications with the transplant course. We know that these patients after the retransplant will spend more time in the hospital, there'll be more time on the ventilator, and their FEV1 is not going to be the same as the initial FEV1 accomplished during the first transplant. But if you look into survival in highly selected patients, it can still offer a reasonable survival and quality of life, someone that is otherwise stuck with advanced forms of rejection. Next slide. There's a few aspects that are very important when we consider retransplantation. One, it's very important that you recognize what was the cause of the failure of the graft to begin with, so you can make sure you're dealing with a modifiable risk factor. If it was a bad reflux episode that can be fixed, for the second transplant, that's reversible. If you have someone that developed really bad DSAs, you're going to have to avoid those DSAs for the next retransplantation. So avoidance of antigens. So certain things you want to look into. What are the risk factors for this to be a problem in the second transplant? And one of the things that is being clearly established is that the longer run you have after your first transplant, the much better you're going to do after your retransplant. Because if you lose your graft within a year, we probably don't know what caused it, and we probably don't know how to reverse it. But if you have someone develop CLAD after 5-6 years, they're more likely to do better after a retransplantation. And we know for a fact, and this is like a rule of thumb for, at least for our institution, we will not be offering retransplantations for someone for PGD or someone for RAS CLAD. We said that we're going to offer retransplantation to someone will be someone that fulfills these criteria, that had a good run, reversible causes, and mainly, if not 100% for the BOS phenotype, because the experience with retransplantation for RAS is being very poor. Next slide, please. And with that, we're concluding the diagnosis and treatment and prophylaxis. I'm going to go back to Dr. Villamizar to talk about some future direction and closing remarks. Thank you, Jen.
Thank you, Juan. Okay, so these are some of the emerging tools to improve CLAD with detection and patient outcomes. So in the following 4 slides, we'll talk about cell-free DNA, how detecting cell-free DNA is a promising non-invasive biomarker for early CLAD prediction and distinguishing rejection from infection. We also talked about the study of persistent de novo DSAs, where only persistent can predict CLAD and AMR, and early treatment of persistent de novo DSAs may improve long-term survival. We also have some molecular diagnostic in the molecular T-cell TCMR, which outperforms histology in identifying therapy-responsive patients, which they can reduce the diagnostic discrepancy. And we're also going to talk about the PDL1 and the PCAM1 molecules, which tissue expression of these molecules can serve as an accurate ACR diagnostic marker and is going to enable more precise immunosuppression therapy. So our colleagues in Sweden, they looked at 246 serum samples analyzing from 26 lung transplant recipients, and they used 4 different measurement methods. And what they found is there was a statistically significant of cell-free DNA elevation in CLAD versus non-CLAD across all methods. So clinically, what this implies is that this may help us predict CLAD onset, can help us differentiate any acute injury EA like rejection or non-infection, and can enable non-invasive monitoring. Following on that, we have the Vienna study done on de novo DSAs. So they looked into 405 lung transplant recipients that developed, of this, 205 developed de novo DSAs, and they have persistent de novo DSAs linked to CLAD and AMR. So the transient de novo DSAs have a better prognosis, not significantly associated with CLAD or AMR, and they had a higher CLAD-free survival rates, which in comparison to those patients that had persistent de novo DSAs, they had a higher risk from treatment needed. They have significantly associated with CLAD and AMR, and they have lower CLAD-free survival at the same 1, 3, and 5 year post-transplant. And the studies done in Prague, so they look into the molecular versus the histological diagnosis for rejection. And the 54% of these cases, they show some discrepancy between histological and molecular diagnosis. Basically, the treatment response rate with the molecular TCMR was 50%, and looked into comparison with the 14% of no-rejection diagnosis. And they're looking into these 2 biomarkers, which is the PD-L1 and the PKM1. The PD-L1 significantly, they were elevated in the ACR group, which signals the immune system that is actively trying to suppress any rejection response. And the PKM1 was elevated levels observed also in ACR, which when you combine with the PD-L1, they may improve diagnostic accuracy for early rejection identification. And some other novel pathobiological insights, we have the complement regulation and the DPP4 inhibitors, which are called also the gliptins. The complement regulation, which is the C3 polymorphism, is found in 1 to 3 lung transplant recipients. And basically what they found is that it's associated with significantly worse CLAD-free survival, and it impairs the complement regulation, which drives just this intragraft accumulation of memory B cells and antibody-secreting cells. This leads into an elevated DSA levels and just creates a self-amplifying alloimmune loop. So this is another like therapeutic target, the complement pathway inhibition. And the counterpart, which is the CD26 inhibition, there's a multi-center analysis going in 6 North American lung transplant centers. And they looked into how this CD26 DPP4, which is expressed in activated T cells, can drive pro-inflammatory pathways and can contribute to CLAD. So the early gliptin use within 90 days post-transplant significantly may decrease the risk of definite CLAD. So the gliptins are already widely available. It's used in diabetic patients. So we still need some prospective clinical trials to confirm this association. And looking to active and upcoming clinical trials, we have the KD025. Basically, they use the belumosudil, which is a ROCK2 inhibitor, which reduces inflammation and fibrosis. This is an ongoing double-blind placebo-controlled trial. And they're looking into bilateral lung transplant recipients with progressive CLAD despite azithromycin. And it entails a 52-week treatment. The second one is the tocilizumab, which they use, it's an IL-6 receptor blocker, which we're familiar with, which is targeting autoimmune inflammation. And this is a phase 3 randomized controlled trial. And it's just 350 primary lung transplant recipients that are randomized to 6 doses over 20 weeks, comparison with a placebo. And their composite endpoint is CLAD, relisting, or death. And the third one on this slide is the ARENA-1 trial, which is basically a nebulized immunomodulatory agent, which is targeting airway inflammation. And they're going to compare the use of ARENA-1 plus a standard of care versus standard of care alone. And last but not least, this ongoing trial in the UK, which is called the ECLAD UK. They're looking into the ECP in the treatment of CLAD. And what they're looking into is a 6 years median post-transplant survival, zero proven treatment for CLAD, and it's the first multi-center RCT for ECP in CLAD. And what they're doing is a phase 2 prospective multi-center open-label RCT, looking into 90 bilateral lung transplant recipients with CLAD between stage 1 and 3. They're randomizing 1-to-1, which is ECP plus a standard of care versus the standard of care alone. And this is in all 5 UK adult lung transplant centers. And what they're looking at, the intervention is basically 9 cycles over 20 weeks, of which are 18 individual 2 to 3 hour treatments every 2 weeks, then every 4 weeks. And they follow all participants or all patients for 24 weeks. Their primary outcome is to look in lung function stabilization at 24 weeks, and their secondary outcomes will be rate of decline in FEV1 and FPC at 24 weeks, which is at the end of the trial, exercise capacity measured by 6-minute walk test, the quality of life issued in the SV36 questionnaire, CLAD disease severity, and survival and safety adverse event. So we're looking forward to the end of this trial, which is around 2028. And with that, I conclude the future remarks. I want to go back and take us to the case where we started the presentation. And this case was the resolution for this case. We were able to do a retransplantation in July 2nd of 2025. So basically, she failed also steroids, the time. We did attempt at ECP, we could not done it. We identified that she had pathological GERD. So she was selected because of the reasons we had explained before, right? Refractory CLAD despite all therapies, BOS phenotype, which has a better prognosis, no major comorbidities precluding her for surgery. She had an acceptable functional status despite her decline in FEV1. We are considered experienced multidisciplinary team, and her cross-match was negative. So key take-home points in this specific case is that she had multiple risk factors that converge, right? She had PGD, she had Pseudomonas infection, she had multiple episodes of ACR, and she had GERD. So on the following slide, I'll show you that her explanted show fibrosis, which is confirming our BOS. And obviously we failed, or we were not able to start the ECP therapy. So this is just both explanted lungs, both the pathology were consistent with BOS. And this is her X-ray, most recent X-ray actually, when she came to visit us at the clinic. Her spirometry on the right side of my screen, her FEV1 is at 1.85, her FPC 2.24, and we did fundoplication surgery for this patient actually. It was within less than 6 months after transplantation. And just as a closing, this is a CT scan, which should be, it's a video. Most recent CT of her chest, on her just as a surveillance once. I thought it was nice to have a video for you guys. And pretty normal. And then my next slide will be just my key takeaways for all of you is that CLAD affects 50% of recipients at year 5 and 70% at year 10, which is the leading cause of late lung allograft failure. Phenotyping is critical, already established for us to carry significantly worse survival, and it responds poorly to major therapies. And we have to look into multiple converging risk factors that will drive CLAD pathophysiology. We have to screen, we have to treat proactively. Our treatment options remain limited, but we still, the earlier the better. And retransplantation for CLAD should be considered only in highly selected patients. And with this, we conclude our talk and webinar. Thank you so much. Now we're opening for questions, discussions, comments.
Yeah. Thank you very much. And it's been wonderful talks by both Dr. Jenny and Dr. Fernandez. And I would encourage all the audiences to put in their questions in the chat box. And to start the ball rolling, I would start with a couple of questions. Regarding your case, which you presented, Dr. Jenny, she had a significant GERD. Was the fundoplication offered for her, and did she undergo a fundoplication or not?
Yes, actually, yes, she actually had her fundoplication done less than 5 months post-transplant because she was transplanted in July and we were able to do her reflux surgery in November, which was successful. And like we mentioned, we are doing this as a standard of practice in our center. So we're trying to like be very proactive about having our GI testing done.
Sure. Another question is like there is a lot of data about lung microbiome and the onset of CLAD, whether it is predominantly the airway colonizations, what we see frequently now, whether it is Pseudomonas or Aspergillus. So despite giving IV intravenous as well as nebulized therapies, if your BL cultures repeatedly grow the same bug, that itself indicates that the airways are now getting colonized. So any thoughts on how do you treat the airway colonization? Because despite a prolonged therapy with intravenous and nebulization, sometimes the bugs just don't go away. So any idea or thoughts about how do you treat the persistent airway colonizations? Any one of you, I mean.
So we all have that patient that, no matter what you do, you try to eradicate things and it just doesn't happen. I think the most common thing will be the Pseudomonas patients in someone that is already establishing some level of CLAD, when you see already some airway remodeling and some bronchiectasis. So our initial approach is for the first patient getting Pseudomonas for the first time. We try to do a very aggressive antibiotic regimen, and we don't do anything crazy. We just focus in making sure that you never do less than 2 weeks of antibiotics and see if you can get rid of it. On the second intervention is inhale antibiotics, and we typically keep them for at least 12 weeks. If someone has recurrence of Pseudomonas, then we go back to treatment, IV or oral, whatever is susceptible, and then we add the inhale for at least 12 weeks. I think our success is being very variable. So sometimes we eradicate it, sometimes it's persistent, and once it's persistent, what we've done sometimes is just to extrapolate some data for CF and then just keep it on inhaled antibiotics, but alternating two agents every other month, like Astronam with Toby, and then you alternate with colistin. Not a lot of data for doing that, but when we see this, that's what we do in the hopes that we're doing the right thing. But we don't really know how to manage the ones that are still colonized.
I think precisely. I think we also face the same challenges for the persistent chronic airway colonizations. Any ideas on or thoughts on using bacteriophages in such setting?
We haven't really been exposed to that here in Miami. We definitely didn't really have that available to us. We propose the use of doing this for patients with mycobacterial abscessus. Just bridge them into transplants already have established advanced lung disease, but not a lot of experience from our part.
Okay. Coming to the cohort of patients of scleroderma, predominantly those who have ineffective esophageal motility and a lot of GERD. So yes, in routine non-scleroderma cohorts, you can go ahead with the fundoplications and have contribute to the symptoms and to the mitigation of symptoms and try to treat the GERD. But how do you deal the cohort of scleroderma patients where it is a bit challenging?
Yeah, I can actually chime in on that one because we actually have this patient in the ICU with scleroderma, has been very complicated pathway. But with her, and Dr. Fernandez can correct me if I'm wrong, like we usually do like strict MPO pathway because we want to bypass like any issue with esophageal dysmotility or any problems like right after like right acute transplant. So we do strict MPO. Those patients we do gastrostomy, jejunostomy. Because we usually, when we're in the ICU before doing the PGJ, we do the enteral feeding post-pyloric, but then we need like a more permanent pathway, or at least until we can see any recovery. Is that anything else to add?
Yeah, so that's $1 million question. Right? What do we do with a patient with scleroderma? And I think if you're looking into all the optimistic reports and looking into retrospective data, comparing scleroderma patients with non-scleroderma patients, the survival, surprisingly, is similar. So I think but we all encountered that patient that did poorly, right? After aspiration and doing terrible and having early CLAD post-transplant. And I think that the caveat is that not every single scleroderma esophagus is the same. And we published a paper a couple of years ago looking into other esophageal motility data. And this was when I was still in Canada. And we look into all the esophageal manometry testing and outcomes with CLAD. And we found that the patients that had the worst motility findings based on the Chicago version 4 classification, which tells you 100% failed contractions. Those are the patients that start with CLAD very quickly. And then the other phenotype was your achalasia patients, the tight LES patients, either achalasia and achalasia obstruction. Those did very poorly. So it tells you that perhaps there's a proportion of scleroderma patients that might have the affection of the esophagus, but it's not necessarily 100% contraction. Now, how can we identify these patients? Is depending on your testing availability and how comfortable your motility team is doing this testing with patients with advanced lung disease. So in Toronto, we didn't really have the capacity to do this pre-transplant because the acuity was very high. Here, we encountered the same problem that we do testing after the fact. But the patients that have some indirect findings of severe symptoms, let's say someone with scleroderma that is symptomatic. To me, a scleroderma with symptomatic symptom, that tells you that patient is doing horrible because a lot of these patients are asymptomatic despite having 100% failed contraction. So selection criteria, have a scleroderma patient that is actively aspirating pre-transplant, that's a no-no. And then we look into other parameters, the diameter of the esophagus, the air fluid levels in the CT scan, to kind of have an idea how severe this is. And if you're otherwise an acceptable candidate, we'll do an MPO pathway, GJ tube insertion, and repeat the test 3 months post-transplant. So we're committed to a 3-month MPO status with GJ tube insertion. So G for decompression in case the delayed gastric emptying arises after surgery that complicates things, and J2 for feeds, so the distal jejunal feeds. And then we reassess things, not because we think the esophagus is going to get better, it's because you're taking away the other factors that might make things worse. The oropharyngeal issues that happen with the surgery and the mechanical ventilation that goes away after. The delayed gastric emptying that starts recovering like 2 to 3 months after surgery from the nephric injury or high levels of CNI. So just trying to optimize the other factors that might exacerbate it. So those patients will do MPO pathway retesting and hope for the best. Mixed results, as you can imagine, Dr. Shah.
Sure. So there is one question from the audience. What is the risk of CLAD in single lung transplant? And do the vocal cord palsy increase the risk of CLAD in post-transplant?
So a patient with lower lung function as a baseline will be, by definition, more likely to develop CLAD. And we see this with blood patients, lower survival. We see this with single lungs. So it's tricky to make the diagnosis in single lungs, because especially when it's like a few years post-transplant, because you're just assuming is the transplanted lung that is getting worse and not a native lung that perhaps is getting more fibrotic or you have more hyperinflation. It's always tricky to make the diagnosis. I don't think there's a pathophysiology link, but it might be a PFT implication that those PFTs are probably going to drop faster because your baseline is lower, and then you have another lung disease that is hard to interpret it. But I haven't seen any publications looking into that specifically. The same for vocal cord paralysis. I haven't seen data suggesting that being linked with rejection or CLAD, unless it's linked to aspiration events. And when we do the fundo application, it's typically done with a toupee rather than the Nissen application. So not a full wrap.
Another question is regarding the as we all know that the BOS, the phenotype of CLAD, behaves more of like the pulmonary GVHD, what the the hematopoietic stem cell transplant recipients encounter as a complication. So there has been a lot of data about JAK2 inhibitors which have been used in pulmonary GVHD, and there has been some interest in the last 2-3 years. One of the article being published last year also about the JAK2 inhibitors. So any role of using JAK2 inhibitors in CLAD, predominantly the BOS phenotype?
So I haven't really seen robust data that would suggest this should be a standard of care. What I've been seeing is in some of the patients that were taking, I don't know, for example, Jakafi pre-lung due to GVHD that needed transplant. I've encountered a lot of side effects and issues when you add on into the immunosuppression regimen. To the fact that as a program, when we have someone with GVHD going into transplant that is on Jakafi, we just go back to standard immunosuppression and we stop it and we don't resume it. Whether there's a role in CLAD, I don't think we're there yet, but looking into what the data comes in the future.
Okay. The next question is regarding ECP, and once you start the ECP cycles, there are multiple cycles, and we have the protocol. Everyone is aware about it. And when do you actually stop the ECP?
Yeah. If you want to multiple, I guess the answer is depend on multiple variables. So for
Right.
this strict definition of how the trials were designed, we were looking into the non-responders, right? And I think like the way they define that in most trials, at least the ones done by Alberto in Vienna, were like, if you have an ongoing decline FEV1 despite ECP for more than 10%, then you say you're not a responder, and then you consider it futile and you stop. And I think that's kind of like the more straight question. But what we really see a lot is the patients just wanting to stop because they're tired, they already CLAD, and they don't want to keep going to do the sessions, and you consider their quality of life, and then you just stop therapy. But
So I think even in the good responders also, I mean, there is no clear-cut data or the answer to suggest that, when do we stop ECP? It's probably the patient's choice, whether they want to still continue or not.
That's a big part of it because of what implications of getting ECP.
Right. So another question about Dr. Jenny. You mentioned about the persistent de novo DSS. What protocol do you follow for tackling the persistent circulating de novo DSS? And how do you, which all the other agents or molecular agents or biologicals what you use?
So actually, when that paper came out, we did have this discussion among our group as in a journal club in the sense of like, should we be more aggressive into like flexing those patient plasmapheresis? Because basically when we have our protocol, which is the same Toronto protocol that we do plasmapheresis and the thymo. So I don't think, correct me if I'm wrong, Dr. Fernandez, but we haven't had like a final protocol of like, what are we going to do with patients with persistent DSAs that are not actually clinically relevant, like the patient is not having any clinical symptoms or.
Again, the other $1 million questions is like, how do we stratify these DSAs? And we do see a lot of DSAs in our programs because we do the desensitization protocol. And as you know, if you look at the paper, you see a lot of these DSAs that never disappeared. And we don't really have and still have outcomes in terms of survival being equivalent and even CLAD rates being equivalent after the last paper that Megan Aversa published. So the bottom line is that if someone is stable, PFTs, cell-free DNA, and they have persistent DSAs, I think that one of the few things that we do always is making sure you're optimizing immunosuppression. And I know some people feel very uncomfortable with high levels, but we're very comfortable with levels. In my first few years in Toronto, we were running levels between 15 and 20 the first 6 months, which is crazy high. But this was for the sensitized patients. And I think if we keep someone in between, in the 15s, 12 to 15s rate, it should be doable. And the other thing that we do is trying to make sure that we provide some IVIG. There's really not a strong data in IVIG, but we routinely do it. There was some paper a long time ago from Columbia, from Luke, showing some improvements in DSA. If you do monthly IVIG, and we'll try that for 3 months, we check DSA, see where we are. But we'll have a threshold to treat them even in asymptomatic patients. By asymptomatic, I mean stable PFTs. If we see a few things, if we see AlloSure creeping up, if we see biopsy positivity in someone that's still asymptomatic, or sometimes we still do biopsies on those patients that are high risk. And the third one will be if we have a C1q status on the patients that we really are concerned about. Not a lot of data, that's all anecdotal, but it kind of tells you that this patient might get worse. So some of those patients we've done early plasmapheresis and then just keep the immunosuppression high. There's been very, very few patients that we did thymo for the second time. Because
I think
the thymo, we didn't do thymo again.
True. I think we also have been using a lot of IVIGs in the subsets and cohorts, what you mentioned about the asymptomatic persistent circulating DNA, donor-specific DSS. Coming to one or two questions which are a lot of interest nowadays, and maybe not much data about the Treg cells. So predominantly the Treg cells and a lot of therapies in the research arena right now of transfusing Treg cells to cause immune tolerance, and so any thoughts on what would be the future of using the Treg cells in the CLAD prevention? Any one of you? I mean, I know it's something which is still into the future, but then
Into the future,
I think
so-
we have covered most of the points, practical points relating to CLAD. So I thought let us go into the future and discuss one or two points regarding that. It's pretty exciting area about, how do we do the immunomodulation, and specifically, there was a paper from Toronto from Professor Keshevji about, creating super lungs, using the next generation, and you can use the adenoviral therapies to deliver the genes, and so a lot of things happening. So about the Treg cells predominantly, how do you look into for the CLAD prevention?
So I think one of the excitement of doing ECP was, I think, the effect on the T regulatory cells, and we've seen some early experience in RDS and severe lung injury that is reassuring in terms of maybe developing a pathway for pulmonary healing. I haven't really seen any robust data that is ready for clinical applications. I don't know if Jenny had a chance to run into something more recent, because I haven't explored this in a long time. But yeah, I wouldn't know that we're prime time for it yet, but it is exciting.
No, like the things that I went through over the new research that was actually organized this summer is like, there's a lot of things coming. I just think we need a little bit more of time, but it's exciting to have more options.
Okay. There is one more question from the chat box. Is vanishing bronchus the sign of CLAD?
I just don't think we know this is a sign of CLAD. We don't know what the implications is. Of course, if you have a vanishing bronchi, you're going to have declining lung function. Although you also have that with obesity. You have declining lung function because of restriction from extrapulmonary. I don't think we have the connection established, to be honest, and unless someone else here has a established pathophysiology connection, I haven't seen it before.
How frequently have you been doing lung biopsies after 1 year predominantly? And do you rely more on the cell-free DNA to guide about, and obviously the clinical parameters, and to guide whether you need to do the biopsy? And secondly, have you been using MMDX, or it is just one paper which everyone goes through and presents in all the talks, but I don't see any of the paper regarding MMDX. So it's the same study which keeps repeating in multiple talks, but any further light on the MMDX which would guide? So how frequently, first question is, how frequently do you do the lung biopsies after 1 year?
Yeah, I can start the first part, and clearly our practice is evolving. Our initial protocol was doing a biopsy at 4 weeks, 3 months, 6 months, 9 months, 12 months, and then by indication, right? We've seen and learning as we're using more cell-free DNA that the negative predictive value makes us comfortable enough to start backing off on bronchoscopies, and to the point that now most of us, in a not a very well protocolized way to do things, because we're just learning about AlloSure, has really decreased our practice on bronchoscopies quite a bit. And I have to say that most of our group only do the third biopsy, and then they just ignore the other biopsies unless there's any clinical indication of the AlloSure is trending up. And we use not only the absolute value of the AlloSure, but also the trend, and looking into the delta changes, which is going to be published this year.
I think there was also a paper about the relative change value, RCV, which was published about if you have more than 80%, then 70 to 80%, then itself indicates that it's a significant jump in the cell-free DNA. So I think
the delta change is very important, because you cannot assume everybody has the same baseline. Yeah.
Yeah, I think most of the discussions we have already touched upon various aspects about CLAD. It's been a wonderful discussion, and I would like to thank both our speakers and also the organizers of this webinar, Dr. Talla and Dr. Aditi, for this wonderful webinar. Over to Dr. Talla.
Thanks, Dr. Urmil. Thank you, Dr. Juan and Dr. Jeannie. Amazing talk, covered the whole aspect of CLAD, and Dr. Urmil really took the conversation to a very practical aspect with all the relevant questions. So thank you all again for participating in the webinar. We hope to keep you all in the loop, and if there are any future talks related to your areas of specialty, we would love to have you on board again. Thank you so much. Thank you, Dr. Aditi. Any parting words?
No, thank you so much. That was an excellent webinar, really exciting, engaging, and thought-provoking, data that you shared, and really wonderful discussion by Dr. Unmil Shah as well. So thank you so much. It was a great honor having both of you here with us.
Thank you for
you.
the invitation.
Thank you for having us.
Anytime.
Thank you.
Thank you.
Thank you.
Have a good evening, guys. Bye.
Good evening.